Welcome to the third cardiology webinar, and we're covering atherosclerosis and ischemic heart disease. For those who are currently in the actual hangout, you can butt in, you can ask any questions you like, and I'll be asking you questions and quizzing you as a teaching tool. For those listening to the broadcast, you can also ask questions via the Q&A app. There's a button on the top of the broadcast when you actually watch the broadcast in full screen. It's got 9 squares. You press on that and you press on the Q&A, and then on the top right hand corner, you will see so on the right hand side you'll see a bar where you can ask some questions, and I'll be able to see them and answer them. So I do encourage you to talk. I do encourage you to contribute. I do encourage you to ask some questions. So anyway, you can see, James, you can see my my screen, yeah?
Yep.
Okay, no worries. So have you done atherosclerosis like as a PBL or in the past?
Not really. It's been taught a bit in year 1 and 2, of course. I don't think that I've had the dedicated PBL on it yet.
Okay, understood. Okay, so the first thing about atherosclerosis is that it's effectively, in short, a chronic inflammatory reaction of your blood vessel, of your large blood vessels. Okay, so if you were to take a cross section of your blood vessel, so I'll just actually I'll just make this a bit larger. So just some revision, because it's good, whilst we study atherosclerosis, it's good to study some anatomy and histology as well, especially for the 4th year VIA. So if this is a cross section of your blood vessel, right, and this is your lumen, okay. Okay, so I'll just draw another layer as well. Okay. So we've got 3 layers, 1, 2, and 3 in our large blood vessel. So the internal layer, what do we call that, James?
The intima?
Yeah, tunica intima. Yeah. It's a pretty self-explanatory name, isn't it?
Yeah.
Yeah. Intima, intimate, inside. And the second one is?
Tunica media.
Tunica media. So what's in the tunica intima? What's in the tunica media?
In terms of what?
What sort of cells? What sort of tissues?
Oh, okay. So in the tunica intima, you've got the endothelial cells.
Yeah, the endothelium. Yeah, good. And what's below the endothelium?
Your sort of connective tissue and your smooth muscle. Well, I suppose smooth muscle in the tunica media.
Yeah. So it's a basement membrane. It's your endothelium plus the basement membrane. Yeah.
Yep.
And it's your tunica media that contains your vascular smooth muscle. Yeah.
Yep.
Okay. And your basal membranes in your intima. And then on the outside layer, you have your tunica what?
Externa.
Yeah. How easy is that? Yeah. So in your very large blood vessels, your tunica media also contains elastin as well as collagen and smooth muscle. Now, generally, chronic inflammation is about so an infiltrate of macrophages and lymphocytes and remodeling of your collagenous tissue. So breakdown of collagenous tissue and laying out new collagenous tissue, which sometimes changes the arrangement of your collagen fibers. In fact, this is exactly what happens in atherosclerosis. So let's actually go through the process of atherosclerosis, and you'll find that you'll see similar processes occurring in acute inflammation. So I'm going to take a different cross section and start off with the endothelial cells themselves. Now, mind you, I am no artist, so I do apologize if my drawings don't look pretty, but so long as they're pictorially accurate. So we've got our vascular endothelium here, and below the vascular endothelium, we've got your basement membrane. Now, what causes an acute inflammatory process is when you have some sort of injury to a tissue. So a tissue may have cells dying, releasing potassium ions, or you may have an infection which contain of viruses, which may contain capsid material, or bacteria, which may contain lipopolysaccharide or other antigenic substances which are detected by toll-like receptors in your sentinel cells, such as macrophages and dendritic cells. On this occasion, what happens is that your endothelium itself is subject to injury. So, James, what sort of factors can cause damage to the endothelium? Irritation.
Things like hypertension.
Yeah.
I suppose hyperlipidemia.
Yep. So low density lipoproteins specifically. Good. Hypertension. How does hypertension do it?
Increased blood pressure, obviously, but increasing the shear stress.
Yeah, shear stress. You're basically when you've got blood pumping through the vessel at high pressure, you're basically shearing off endothelial cells. You're applying physical trauma to the endothelium, and physical trauma itself can damage the endothelium, can't it?
Yep.
Yeah, good. So hypertension, low density lipoprotein. What else?
Things I suppose like things like smoking or increasing age.
Yeah. So the thing with age itself doesn't cause atherosclerosis. Age just give you, if you're older, you have more time for atheromas to develop. Yeah.
Okay. Yep. Does the endothelial lining naturally sort of worsen over with age, or is that maintained and it's the other factors that contribute to it?
I'm actually not sure of that. But
all right, that's all right.
My guess would be that like as you get older, you'd be exposed to substances or shear stress, which will cause some sort of atheromas to form. The idea of age is just time, as opposed to the aging process. Do you follow what I mean?
Yes. Yeah. It's
Okay.
probably pretty hard to separate the two anyway.
Yeah, pretty much. So you've got hypertension, low density lipoprotein, smoking. What else?
I'm not sure. I suppose, yeah, anything sort of like infection, I suppose.
You're actually correct. Infection. Sometimes you have subclinical infection by, for example, have you heard of a bacterium called Chlamydia pneumoniae?
Yes.
Yeah, Chlamydia pneumoniae has, in many instances, been found to be implicated in abdominal aortic aneurysms. So when you get atherosclerosis, it causes two things. One, it causes atherosclerosis to develop a narrowing of the arteries. The second thing it causes is that, well, when you have chronic inflammation, sometimes your collagen gets thinner in your tunica media. When this happens, your blood vessel becomes more compliant and you actually can get an aneurysm, yeah?
Okay.
In the very large vessels, atherosclerosis results in aneurysms. In smaller vessels, it's blockage. So Chlamydia pneumoniae can, as an infection, can actually infect blood vessels. And you get atherosclerosis occurring throughout your body. So it is a risk factor, absolutely. In fact, there is talk of macrolides being used in prophylaxis post-AMIs to prevent further myocardial infarctions from occurring, because we acknowledge that chlamydia pneumonia may be a factor that can cause atherosclerosis. Interesting, isn't it?
Yeah, it is. Is there any current way of testing for chlamydia pneumonia?
I'm actually not sure. I don't know.
Okay. No, that's all right.
But I'm glad that you mentioned infection, because yeah, infection is a cause of inflammation. What else? So what about hypoglycemia?
Yes, those are going to be my next one. Yeah, diabetes and hypoglycemia.
Hypoglycemia. So diabetes, absolutely. Glycemia. And then after that, there are some smaller ones, such as, you might have heard about homocysteine.
Mm-hmm.
Yeah. You may also have heard of C-reactive protein, CRP itself.
Okay.
Okay. And now I've got one more. Let's see, what else have I missed? Okay, I've got one more question for you. What is the most common cause of... did you come to my revision lecture on cardiology?
I did, yes.
Yep. So what is
I'm not sure if I should say that now that you're asking me a question.
All right. So what is the most common cause of death in patients with chronic renal failure?
Cardiovascular disease.
Yeah, absolutely. Why?
That I'm not sure about.
No, that's fine. I'm just asking these questions as food for thought. The reason is because when you have renal failure, you become uremic, yeah? Uremia actually means you have a number of unnamed toxins, number of metabolic waste products that you can't excrete, including methanoate ions, etc., etc. It doesn't. Urea itself is actually rather harmless. The reason you get the symptoms of renal failure is because of the other metabolic waste products that you can't excrete, which are largely unnamed and numerous.
Okay.
These metabolic waste products themselves can cause rapid atherosclerosis. So renal failure is a cause of atherosclerosis. Now, another question. Have you noticed that patients who have chronic inflammatory conditions tend to get atherosclerotic disease, rheumatoid arthritis, psoriasis, etc.? Have you noticed that?
Possibly slightly, yes.
Yeah, the reason is because chronic inflammatory conditions, chronic inflammatory diseases, all accelerate the process of atherosclerosis by means of a number of mechanisms, including the action of interleukin-6. Do you know why? When you have rheumatoid arthritis, when you develop rheumatoid arthritis, the gold standard treatment, if you have $1 zillion, is straight to biologics. Yeah, the only reason we start with prednisolone, methotrexate, and other DMARDs is because we don't have the money to afford billions of dollars worth of biologics, such as infliximab or adalimumab or tocilizumab, etc. Yeah.
Mm-hmm.
Why is it that when you have patients with rheumatoid arthritis, we are so aggressive in treating them? We don't start sparingly. We treat them aggressively because we want to reduce the risk of cardiovascular disease. Cardiovascular disease risk increases significantly in patients with rheumatoid arthritis. And the big reason is because you have a systemic chronic inflammatory condition, which itself promotes atherosclerosis. This is not just for rheumatoid arthritis. It also occurs in psoriasis as well.
Okay. Yeah.
And interleukin-6 is one of the big mediators of that. Interleukin-6 itself is an endothelial irritant. Yeah.
Okay. Yep, that makes sense.
Okay, so these are the different causes of endothelial injury. So now let's start with endothelial injury. Let's see how the endothelium responds to that. So what I want to ask is, go back to year 1. Let's talk about acute inflammation. What does vascular endothelium do during the acute inflammatory response?
I suppose it recruits the inflammatory cells into the endothelium.
Yep. How?
Then, I presume by sort of, by the sort of the adhesion proteins or something like that.
Exactly. Adhesion molecules. Yeah. Adhesion.
Molecules.
No, exactly, absolutely correct. Your endothelium becomes sticky. The term I like to use is sticky. It becomes sticky to white blood cells. Yeah?
Yep.
What else happens to the endothelium in acute inflammation?
So the gaps between the endothelial cells sort of allow more cells to pass through them.
Yeah, bingo. Your endothelium becomes wider, doesn't it?
Mm.
Your endothelium becomes more permeable to substances. So as you can see, what I'm drawing now is just your endothelium increasing in permeability, right? Now, this is acute inflammation. We are just talking about regular acute inflammation, right? Ignore my drawings for now. And also, your endothelium becomes more thrombogenic. Platelets can adhere more strongly onto it, yeah? That's your typical acute inflammatory response. Now, what if I told you that the exact same thing happens, practically the exact same thing happens in atherosclerosis, doesn't it?
Okay.
So what's actually happening is mirroring an acute inflammatory response.
But just chronically.
Yeah, over time, because the thing with the things that cause atherosclerosis is that the factors that cause atherosclerosis are persistent. You have persistent hypertension, persistent hyperlipidemia. If you smoke, you don't just smoke the one cigarette. You keep on smoking for years and years and years.
Yep.
Yeah? Okay, so what happens when your endothelium, when your endothelium becomes more permeable. In atherosclerosis, you have low-density lipoprotein entering, don't you?
Yep.
Low-density LDL starts entering this is the intima. This is all the intima, yeah?
Okay, yep.
Yeah. Now, what I'm going to do is I'm just going to scroll down and draw a new diagram in a bit more detail. So here's your endothelium. So now your cells are a lot more permeable and they are sticky. They've got adhesion molecules, yeah? And we've got our basement membrane. And I'm just expanding it so that I can actually draw the events that are occurring inside the intima. So this is all in the intima, okay? This is all tunica intima, okay? The media is over here, and your media contains smooth muscle. Okay, your smooth muscle is going to be important. Okay, so low density lipoprotein comes in, okay? LDL cholesterol comes in. What else comes in? What is it that your adhesion molecules attract?
The macrophages?
Bingo, macrophages, yeah? Macrophages and lymphocytes, yeah? Now, that's interesting, isn't it? Macrophages and lymphocytes are the chronic inflammatory infiltrate, isn't it?
Yep.
Yeah? So, now, macrophages have a particular liking for LDL cholesterol.
Yeah.
So, they start engulfing LDL cholesterol, yeah?
Mm-hmm.
Now, in short, your macrophages and lymphocytes also secrete a number of cytokines. Because that's what they do. They're inflammatory cells, yeah?
Yep.
So they secrete a number of cytokines which have a number of effects, such as opsonization. So they opsonize more macrophages to come into the intima. They cause an acute inflammatory response here, etc., etc. So more macrophages start to come in, yeah? And they start to collect in your intima. So now, what happens when a macrophage engulfs too much LDL cholesterol?
Becomes one of the foam cells? Or?
Yeah, it dies. It becomes a foam cell, doesn't it? Yeah, so these macrophages, they die, they become necrotic, and they turn into big, ugly, yucky-looking foam cells, yeah?
Okay.
Yeah. And these foam cells start to collect, yeah?
Yep.
Now, I'm just going to get rid of that lymphocyte. The lymphocytes are still there, so the inflammation is still occurring. This is a chronic inflammatory process, which is still occurring. And then you develop these necrotic, dead foam cells. And what you eventually get is this amalgamation of foam cells is just a lot of cholesterol. So this is what we call a lipid core, okay?
Mm-hmm.
Now, simultaneously, it's not just your macrophages that engulf this. When the macrophages and lymphocytes secrete a number of cytokines, some of the chemicals that they secrete are growth factors. These growth factors cause smooth muscle cells to de-differentiate and actually join the party. Yeah? Yep. Smooth muscle cells start to join the party and they do the same thing. They engulf and they become foam cells. Yeah?
Yep.
In the midst of all that, remember, chronic inflammation also involves remodeling of collagen.
That's where you get the fibrous cap.
Exactly. Absolutely. Exactly. So that means some of the cytokines that are secreted here cause fibroblasts in the region, so fibroblasts in your blood vessel, to start laying down collagen, yeah, new collagen. So what you end up getting is a fibrous cap, yeah.
Yep. Okay.
Made out of collagen. Now your atheroma. This is your atheroma, yeah. Your atheroma gets bigger and bigger as more and more LDL gets deposited onto your atheroma. It gets bigger and bigger, more foam cells, more high lipid core, and this fibrous cap. Now, in chronic inflammation, let's talk about another disease where we have a similar pathology. Let's compare COPD with chronic asthma. Why is it different? If you look at patients with chronic asthma and look at their bronchi, their little bronchi, and compare them with patients with COPD, what differences do you notice?
Well, I suppose in COPD you've got the chronic bronchitis side of things.
Yeah, but keep in mind that chronic asthma is also a chronic bronchitis. It's just that the cause is different.
Oh, okay. I'm not sure in that case.
Sure. So the concept here is that chronic asthma and COPD are very similar pathologies. They're both chronic inflammation of the bronchi. They're both chronic bronchitis. One is caused by COPD. The bronchitis is caused by smoke as an irritant, yeah?
Mm-hmm.
And mainly neutrophilic infiltrate, whereas in chronic asthma, it's mainly an eosinophilic infiltrate because it's an allergic phenomenon. So but if you look at patients with COPD, usually their bronchi are have very thin walls, yeah.
Yep.
Very thin walls. So the airways are very collapsible.
Yep.
Now, in chronic asthma, this is patients with severe asthma that are not controlled. These patients aren't treated. We're talking about untreated asthma here, yeah?
Mm-hmm.
What would happen if you did a lung function test on patients with chronic asthma untreated? So they have a low FEV1 to FVC ratio. What happens after bronchodilator treatment?
If they've been chronically untreated?
Yeah, if they're chronic untreated asthma.
Their lung function improves because of the bronchodilators, or
that would be true in acute asthma. That would be true in a patient who's just got an asthma.
Oh, okay.
And a patient is treated, yeah, because so the bronchodilator, the airways can dilate in response to the salbutamol, etc. When patients have chronic asthma that is untreated, it's a chronic inflammatory response, and on that occasion, it turns out that the collagen layer in your bronchi thickens. It thickens and it makes your bronchi less compliant, which means even after the bronchodilator, it's not going to work.
Okay. Yep.
Your bronchi remain constricted because you have a very thick bronchus. A very thick bronchus, you're basically turning the rubber band bronchus into a rubber bronchus.
Yep. Okay, that makes sense.
Remember my analogy from the cardio lecture when I was talking about the stiff heart. You're making your bronchi very stiff. Now, in COPD, your bronchi, the collagen is actually very thin. The collagen is actually very, very, very thin, and your airways are very collapsible. Your bronchi become too compliant, basically.
Okay. Yep.
Now, what I'm trying to get at here is that inflammation can either cause a thickening of the collagen wall or a thinning of the collagen wall, depending on the factors that mediate it. So the outcome is variable.
Okay, that makes sense. Yep.
So that means your fibrous cap here in your atheroma may be thick or may be very thin.
Oh, okay. Yep.
Now, I'm going to ask you a question. Which do you think is more dangerous? I'm going to give you two blood vessels, yeah? These are both coronary arteries, yeah?
Mm-hmm.
Okay. So I'm just, this is your fibrous cap, and this is going to peak to 70% blockage of your coronary artery, yeah?
Yep.
This is the cap's a bit thinner here, and this is meant to depict 40% blockage, yeah?
Okay.
Which is more dangerous? A or B?
I would say A, but since you're asking, I'm not sure whether it might be B.
Tell me your reasoning.
I would have thought A has a thicker fibrous capsule, but is imposing itself more within the blood vessel and is therefore exposed to more pressure as the blood tries to get around that atheromatous plaque.
Oh yeah.
On the other hand, on the flip side, B is less exposed but has a thinner fibrous cap. But possibly, I might say B because of the thin fibrous cap.
Yeah.
Is more likely to rupture.
Absolutely. You hit the nail on the head. This fibrous cap is thin and is more likely to rupture. Even here, your blood flow is faster because your blood vessel's not as blocked. Yeah.
Okay.
Blood flow here will be a bit slow. Here it's faster, so you're getting more shear stress on the actual cap.
Okay. Yep.
So absolutely, you're absolutely right. The problem is here. This is more likely to rupture. So when it ruptures, if you were to have a rupture of this plaque, then you will have a thrombosis form here because your cholesterol, your material inside here contains a lot of tissue factor, and tissue factor causes lots of tissue factor, lots of von Willebrand factor, and you have platelet aggregation and coagulation. Your various clotting factors being activated, yeah, and then you have all sorts of problems, yeah.
Yep.
Now let's link this atherosclerosis to ischemic heart disease, yeah.
Mm-hmm.
And if you have time. Actually, no. Yeah. So ischemic heart disease is due to an in situ thrombus. Now, what are the different types of ischemic heart disease that we have learnt about?
I suppose stable and unstable.
Yep. So stable angina. Yeah. Cool. What's next?
And then you've got the acute coronary syndrome.
So you have stable angina. Yep. Unstable angina.
Unstable angina. And then I suppose the non-STEMI and STEMIs.
Yeah, yeah, non-STEMIs and STEMIs. Now, from my lecture, the term acute coronary syndrome is an umbrella term. That's acute coronary syndrome.
Yep.
Okay. This is non-STIAC. Have you heard of non-STIACs?
Yep.
Non-ST elevation acute coronary syndrome.
Yep.
Yeah, so that's acute coronary syndrome. That's NSTIACs. You'll find that the pathologies are rather different.
Okay.
Okay. So in a patient who has this sort of plaque, which is slowly growing, slowly getting bigger, maybe 70%, 75%, etc., etc. Mind you, this blood vessel can be blocked up to 95% until you get ischemia at rest.
Oh wow. Okay.
Yeah. So this vessel can be pretty damn blocked. So in a patient with stable angina, what's happening is do you remember me asking in the lecture who's done high school economics?
Yes, I do. And I'm not one of those individuals.
Oh, nor was I. Don't worry. Okay. So remember how I was talking about supply and demand?
Yes.
Okay, so now what I'm going to do is I'm going to link each of these conditions with the particular pathology over here, and then talk about how it relates to supply and demand, yeah?
Yep.
Okay, so in a normal individual like you and me, okay? Well, hopefully you and me. So, at rest, our supply meets our demand, yeah?
Yep.
Now, when we start exercising or when the heart starts working harder and it needs more oxygen, so the demand for oxygen will rise, yeah?
Yep.
So what happens to the supply?
It increases as well.
For what reason?
Because I'm not sure who the law was, but basically the cardiac output needs to meet the cardiac input.
That's correct. But let's talk about we're talking about a local tissue here. The heart, just like any other tissue, is a local tissue. It regulates its own blood flow.
Okay. Yep.
By what mechanism does it do that?
With the fact that if it's not getting enough oxygen, it's releasing vasodilatory substances and substances that make the body respond, like increase blood to that area. I'm not exactly sure.
You've got half of it. You've got half of it. So yeah, when any tissue, the heart, the muscle, nerves, if any tissue is ischemic, if connective tissue is ischemic, if muscle is ischemic, if the heart is ischemic, whatever. So when they're ischemic, they've got low oxygen. They produce a lot of carbon dioxide, which is not being washed out. They produce a lot of H+. They produce H+ because they're going into anaerobic respiration and producing lactic acid, and they're producing a number of metabolic waste products, yeah? These together all cause vasodilatation. Carbon dioxide is a vasodilatory substance, which is why Have you ever wondered why, when you look at a patient who has COPD, when you take their pulse, you want to check whether it's bounding?
Yes. Yeah.
That's to assess for hypercapnia.
Oh, okay. Yep.
Yeah, a bounding pulse implies hypercapnia because because if you have the bounding pulse implies hypercapnia, because if you have hypercapnia, you have high carbon dioxide throughout your body. Your blood vessels throughout your body will be dilating, yeah?
Mm-hmm.
When you have a very systemically dilated blood vessels, your pulse pressure goes through the roof. You have a high systolic and a low diastolic.
Oh, okay. Yep.
Yeah, so that's a marker of hypercapnia. Hypercapnia, very thyrotoxicosis, any acute systemic inflammation, all cause systemic vasodilatation.
Okay. Yep.
Yeah. So okay, anyway, back to this. So yeah, so the supply will meet the demand, yeah?
Mm-hmm.
And that's all well and good. Now, let's go back to status quo. And let's give this person pathology A, yeah? So they've got a chronic plaque. Their plaque's been there for a while, and they're symptomatic. So they start to get symptomatic here.
Okay.
As in when they start exercising, yeah? At rest, their supply will meet their demand. No dramas, yeah?
Mm-hmm.
Now, suppose they start exercising. They exercise today on Saturday night at 7:35 in the evening, let's say. The demand for oxygen will rise. Now, the same thing will happen with supply. Your heart muscle realizes it's ischemic and releases, the ischemia itself will cause the release of local chemical factors, which will cause vasodilatation. Your supply will start to increase, yeah?
Yep.
The problem is we've got this big atheroma in the way. So when your blood vessels become maximally dilated, your supply may only go up to there because your blood vessels can only dilate so much.
Yes.
Okay. So your supply is like there, your demand's here. You'll start releasing more H plus, more chemical factor. You'll start releasing more H plus. Your cells will become hypoxic, and you get inflammatory pain, which is also known as ischemic pain.
Okay. Yep.
That's your chest pain that you get, yeah?
Yep.
And when you get your chest pain, what also happens is, well, if your heart muscle is ischemic, it starts contracting abnormally.
Okay.
In fact, ischemic muscle doesn't relax properly.
Okay.
Ischemic muscle doesn't relax properly because one of the big energy outputs in a muscle is, when the muscle contracts, when it performs a contraction during an action potential, calcium ions get released from your sarcoplasmic reticulum, yeah?
Yep.
And that's by facilitated diffusion because there's like no calcium in your sarcoplasm usually.
Mm-hmm.
So when the action potential is finished, your sarcoplasm, so your sarcoplasmic reticulum has to reuptake those calcium ions by active transport.
Okay.
By SERCA pumps. Okay, the pumps are called SCRCA. Now, if you're ischemic, you can't do that, can you?
No.
So your heart remains tense.
And therefore it doesn't pump as well.
So yeah, exactly. You have acute diastolic heart failure. Acute diastolic heart failure. Acute heart failure with preserved ejection fraction. Your heart is functionally turning into rubber instead of a rubber band.
Yep.
So what happens when you have acute heart failure? Your left atrial pressure increases. You'll have blood backing up in your pulmonary capillaries and your pulmonary vessels. Your pulmonary blood pressure increases, and you get short of breath.
Oh, okay. Yep.
Yeah. So the shortness of breath is acute heart failure, although transient. Then, anyway, so that's your chest pain and shortness of breath, yeah? Now, when you start resting, you say, oh, my chest. And so you stop and you rest. Your supply will go back to normal. And everything's hunky-dory. That is stable angina. Keep in mind, we've got a fixed plaque.
Yep.
Yeah. So we call this demand-led ischemia. It's the increased demand that acutely causes the ischemia.
Okay. Yep.
Now, if you were to, let's say this guy has run 100 meters, yeah? Now, let's suppose that this guy is an idiot and he says, okay, no, not an idiot. Suppose this guy says, let's actually try again and see how things go. So he starts running again. Demand increases. His supply will increase to the same fraction, yeah, to the same amount, because the stenosis hasn't changed. The ischemic, the plaque size hasn't changed in that time. So you will get the same chest pain, you'll get the same shortness of breath after the same level of exertion, which is why when you ask a patient on history, if you ask a patient on history, after what level of exercise do they get chest pain, ischemic symptoms, you think it's stable angina if they get ischemic symptoms after the same level of exertion every single time.
Yep.
Yeah, makes sense?
Yep.
Okay,
yeah, that makes sense.
Yeah, that is stable angina. Okay, stable angina. Now, this may slowly get worse and worse and worse over time when your atheroma starts getting bigger and bigger and bigger, yeah?
Yep.
Now, let's talk about the acute coronary syndrome. Let's talk about unstable angina and the NSTEMI, which is really a similar pathology. Now, unstable angina and NSTEMI happens when we get what we call a supply-led ischemia. What that means is, say, in a resting patient, your supply and your demand meet each other, but you have a given maximum supply that you can give in any patient, yeah?
Yep.
In the patient with angina, it's a bit lower, but it stays there. The patient with unstable angina, or even an NSTEMI, that maximum supply starts to drop a little bit. So when you exercise the first time, your demand goes here, your supply goes here, you'll get chest pain, yeah?
Yep.
The second time you do it, say after a few days, your demand increases, but your supply only increases by a little bit. You see how the maximum supply has changed?
Yes.
Yeah. So this is what we call supply-led ischemia. So you get shorter breath and chest pain after less exertion.
Mm-hmm.
After less and less and less exertion, eventually, sometimes even at rest.
Okay.
Okay. So that is what we call when this happens. Now the reason why this is actually not so bad is because your maximum supply starts to drop and drop and drop, and so over time it'll rise again and again and again, yeah, to its baseline function. The reason now, how do we correlate this to this setting? The plaque size has to increase acutely over a very short period of time to explain these findings, yeah?
Yep.
So the idea is you get a plaque rupture.
Okay.
What two things can acutely cause the plaque to get bigger? So we've got a plaque rupture. What's the other thing that people don't often talk about?
I'm not sure.
We call it an intraplaque hemorrhage.
Oh, okay. Yep.
Yeah, you can actually get a hemorrhage inside the plaque because you have angiogenesis of blood vessels here, which is weak. These are weak blood vessels, yeah.
Yep.
And they're not structurally sound, so they can burst quite easily. The same thing happens in the eye.
Okay. Yep.
Yeah. So in diabetic retinopathy, that's exactly what happens. Your retina becomes ischemic. You start getting angiogenesis. Proliferative retinopathy, we call it, angiogenesis of vessels that are not particularly structurally stable. They burst, you get a hemorrhage inside your vitreous humor, and then you get blind.
Okay, yep.
Similarly, you can get an intraplaque hemorrhage here, and your plaque gets bigger and bigger from 40 to 60 to 80 to 95, really, really quickly.
Yep.
Or you can get a rupture of the plaque and a thrombus forming here, yeah?
Yep.
And so over a short period of time, your level of blockage increases from 40 to 60 to 80 to 95, etc. Yeah, which is why your maximum supply keeps dropping and dropping and dropping and dropping and dropping. Yeah, which is why you get ischemic after less and less and less and less exertion. Now, the reason that can sometimes get better is because when you form a clot here, we have plasmin. So when you form a clot, and you have coagulation, it also activates the fibrinolytic pathway, which causes fibrinolysis by means of plasmin. Yeah.
Mm-hmm.
By means of antithrombin 3, protein C, protein S, etc. Yeah.
Yep.
Cool. So eventually, the plaque gets bigger and bigger and bigger, and then it starts to regress, and then it's all fine, and then you have a lucky escape. Cool.
Yep, that makes sense.
So that's what we call unstable angina or an NSTEMI. Those two have the same clinical presentation, except in an NSTEMI, you actually have a troponin rise. So you actually, your ischemia was actually just bad enough to cause death of muscle.
Yep, that makes sense.
So you get a troponin rise. So that's the difference between an unstable angina and NSTEMI. So why is it that you get ST depression in these two conditions? Where's ischemia happening?
Well, in the non-STEMI, it's only part of the wall that dies off rather than full mural ischemia.
Yeah, exactly. It's on the inner wall. So if you were to draw a very crude drawing of your heart, yeah, your coronary arteries pierce. They travel in the epicardium, and they pierce into your endocardium. Yeah, your subendocardium. Yep. Because your endocardium itself is supplied by the heart inside the chambers, isn't it?
Yes, yeah.
The endocardium doesn't have a problem. It's a subendocardial layer. Yeah. So if you have, if you have ischemia after exercise, if you have ischemia after exercise, or if in stable angina or in unstable angina or NSTEMI, it's this muscle that starts to die off first. Yeah.
Mm-hmm. Yep.
Now, that is consistent. That is consistent with ST depression.
Oh, okay.
Now, a STEMI is a different kettle of fish. A STEMI is a different kettle of fish. What happens is you get a plaque. Yeah, you get either a plaque hemorrhage, or you get a plaque hemorrhage, or you get a rupture of the plaque, of a weak plaque with a weak fibrous cap. The difference is that it's so bad that you get 100% blockage. Instantly, you get 100% blockage. Yeah.
Yep.
Which may or may not, over time, start to dissolve. But the point is, you start to have 100% blockage. Now that's really bad, because that means if you've got 100% blockage of a coronary artery and you're sitting on the TV and relaxing, yeah.
Yep.
You're sitting on the TV and relaxing. What's going to happen to this profile? Tell me what happens to this profile.
Well, your supply is going to completely drop off.
Exactly, your supply is going to do that, yeah.
Yep.
At rest, you're watching the TV and you get intense chest pain. You can't do anything about it because you can't, your demand's here. That's your lowest demand at baseline resting level. Your supply is already low. That's the maximum supply. So you're in big trouble, aren't you?
Yes.
So that's when you straight away go to the hospital. Yeah, this is serious stuff. This is a STEMI. And in the STEMI, you've got 100% blockage. So it's not just your most vulnerable tissue that dies off. It's the whole damned thing. This is called a transmural infarction.
Yep.
Now that's bad, isn't it?
Yeah.
Yeah, that's really, really bad. Yeah. So, just out of curiosity, at what time of day do you think a heart attack tends to happen? A STEMI.
I'm not sure. I'm going to guess in the morning.
You're actually right, absolutely right. Because in the morning, for some reason, you have this surge of adrenaline.
Okay.
When you have an adrenaline surge, what does that do to your blood vessels? It constricts them, yeah?
Mm.
When it constricts them, it can sometimes mechanically disrupt your plaque.
Okay.
When it mechanically, imagine pulling on your plaque. If you pull on your plaque, you can rupture it, yeah?
Yep.
The other thing is when you have an adrenaline surge, your blood pressure will acutely rise. And so you have shear stress, you have shear stress beating on your weak plaque.
Yep.
And yeah, so that's why it tends to happen in the morning, a heart attack. So yeah, there you go, huh? That's the main, yeah. Yeah. So, what do you reckon?
That's good. Yeah.
It's quite interesting stuff, isn't it?
Yeah, it is. It's fascinating.
Yeah. So yeah, the moral of the story is, patients with renal failure, watch out for cardiovascular disease. Patients who have any chronic inflammatory condition that is systemic, such as rheumatoid arthritis or psoriasis, or even SLE, for example, just watch their cardiovascular risk and chuck them on anti-inflammatories immediately, or DMARDs, or biologics if they're important.
The question I did have was, they say that sort of, one of our lecturers said that there was foam cells that basically all of us at the age of 20 or 25 already had sort of the beginnings of atherosclerosis.
Oh, the fatty streak, yeah.
Yeah, sorry, the fatty streak, sorry.
Yeah.
What causes, I mean, we've got the list of causes there. What causes that to happen in someone who is sort of exercising and who doesn't have hypertension and doesn't smoke? Or is that just...
This is going to be purely my postulate, so
that's right.
I don't claim any accuracy on this. Well, even normal tension, a normal blood pressure, you still have shear stress on the blood vessels, don't you?
Yes. Yeah,
it's
fair
like,
enough.
If you were to have some kind of machine that contains pipes, even if the machine's fully working properly, your pipes are going to wear out over time, aren't they?
Yes.
Even normal tension. Or many of us may have subclinical chlamydia pneumoniae infection. That may be another postulate. Another postulate is some of us may have, without realizing it, some elevated LDL levels as well.
Yes, okay. No, yeah, that makes sense.
Yeah. So yeah, those are my postulates.
Yeah. Thank you.
No dramas, man. I'm glad you came. I wish there were more people here, to be honest. More people in the hang.
That's all right. I enjoyed having the one-on-one session.
Yeah. You had me to yourself.
Yeah, exactly.
It's good to do a one-on-one session. Yeah. Try to invite more people. Try to get more people to come because if you have a good, vibrant Google Hangout, then it'll be more and more popular, and whoever's watching the broadcast will benefit a lot more from the multiple brains that are working. Yeah.
Yeah, definitely.
Yeah,
I'll do that.
No worries. Now, mind you, this isn't fully exam focused. This is more conceptual, so that when you start learning the material, it becomes a lot more easier because it becomes more instinctive.
Yes. No, and it certainly helps, as we're talking about the unstable and the stable and that sort of thing. You understand the pathophysiology behind it.
Therefore, then you can understand the clinical pattern, the pattern of the timing.
Exactly.
Yeah, it makes a lot more sense. And then you can think of the risk factors for all of these conditions very easily. Instead
of rote learning them.
Yeah, I can't rote learn to save my life.
I'm exactly the same.
I can't rote learn to save my life. I wish I could, then I would do better in medicine.
Yeah, exactly.
Cramming all those differentials for all these random conditions. Presentations. But anyways, I'm just gonna. So anyway, that's the end of the. Oh, there's another one of you. I didn't see you.
I think Rowena just joined, sort of.
Oh, she just
a couple
joined.
Minutes ago.
Oh,
yeah.
Fair enough. Because yeah, fair enough. Because I just. Damn it. Because the webinar's finished now. I was thinking, given that Rowena's turned up, I don't want to waste. I don't want to have wasted the fact that she's come in. Do you have any ideas, James? Got another 10 minutes. Do you have any other questions you wanted to ask me? Rowena, you can turn your mic on. Did you have any questions to ask me? Okay, she isn't turning her mic on. Okay.
No, look, I'm not sure. I suppose one of the questions I had is on cardiovascular, but the aortic dissection. Is that the same thing as a ruptured? If aortic dissection occurs in the abdominal aorta, is that the same thing as a ruptured AAA?
Oh, they're different things. Aortic dissections.
Oh yes, of course. Sorry, I've just gone and I've just thought it through.
Yeah, because aortic dissections.
The aneurysm actually bursts, whereas dissection is still is in the wall of the blood vessel.
Yeah, dissection tends to originate in your aortic arch. And then it may migrate proximally, in which it's a type A dissection, or distally, in which it's a type B dissection sort of thing.
Yep.
Actually, out of curiosity, let's brainstorm some risk factors for aortic dissection while you're at it, keeping in mind the things that can cause aortic dissection.
Okay. As in terms of risk factors, or as in the actual causes, I suppose.
Oh, both. Risk factors can be predisposing, can be precipitating. Yeah.
So hypertension again.
Oh yeah, hypertension. Brilliant.
Hypertension, smoking.
Shear stress.
Any of the sort of connective, like Marfan's, the connective tissue diseases.
Yeah, exactly. If you've got weak connective tissues, if you've got weak structures, you're more likely to break through the interval layer. Because dissection is basically when you cut your artery in half through the middle. That's what you're doing. You're cutting your tunica intima in. You're basically taking a slice of your tunica intima and then just cutting it through. Imagine blood dissecting it through.
Yep. Yep.
And then when you actually cut that hole inside your intima, then blood forces itself into the intima at high pressure, and then cuts a bigger and bigger and bigger and a bigger hole, and it just rips along the artery. That's a dissection, really.
Okay. Does that dissection ever burst then?
It can. It can burst. It can burst. And when it does, you have an aortic rupture, and there's no chance of survival.
Okay. Yep.
Yeah. Well, hardly any chance anyway, unless you've got a really good vascular surgery.
Yep. Yeah.
Yeah.
I presume it's the same sort of survival, possibly less as along the as a ruptured AAA. Is that the case or not?
Sort of, yeah. I'm actually not sure. I can't. I can't claim it. The thing with medicine, and like to give webinars like this, I have to be careful with what I say. It's almost like Tony. Do you remember? Tony Abbott. Do you remember when he was giving this? He was in the 730 report or something, and he was talking about how politicians are judged on everything they say.
Mm.
And then he said, the thing you had to take as gospel truth are those carefully crafted, scripted remarks.
Yes, yeah.
Even if you say something loosely or on the fly, it can be a bit inaccurate.
Yes, exactly, yeah.
You're hung to the lamp, you're hung to the wall on whatever you say. So that's why I'm being a bit careful with what I say, because I don't want to...
that's quite... Especially since this is being recorded.
Yeah, exactly, yeah.
Different conversation.
Yeah, pretty much. So yeah, where was I? Oh yeah, we're talking about dissection. Yeah. How about surgery, aortic surgery? You do surgery, you can cut into the intima, can't you, of the aorta?
Yep.
Yeah. So valve. What else is there? Yeah, those are the main things. Yeah, connective tissue diseases, cutting into the intima by surgery, hypertension. Yeah, those are actually the main things. Yeah. Sound good?
Yeah, no, that's wonderful.
No worries. All right. So anyway, that's the end of the webinar. I hope that you've had a good understanding of the material. I hope that you've got a better insight into what atherosclerosis is and how it relates to the different types of ischemic heart disease. And anyway, that is enough from me. Thank you and good night.